recording. Okay, so let's start with this one. This is not going to be a diagnostic dilemma, but just kind of a nice example, and I have some correlation. So this is a 50-some-year-old male patient who presented with a palpable chest wall mass. And all I have is this portable radiograph from the outside, and you can see there's this large calcific mass in the left lower chest. And so presumably this is what he's palpating. The calcification suggests some sort of matrix, maybe a chondroid tumor or a osteosarcoma, or you can occasionally get necrosis or something, a lipoid tumor, but you have to worry about those kind of things or some sort of something. So he then underwent a CT scan, and it shows this sort of dumbbell-shaped mass centered on an anterior rib cartilage, extending into the subcu fat, and then also extending posteriorly into the mediastinum, pushing on the pericardium. And if you look at it, change it, you can see it has very much a chondroid matrix to it. It's not that fluffy look to it. So almost certainly a chondrosarcoma, and so he went for a resection of this, and indeed that's what it was. But I managed to get some pictures, which is what's so cool about it, just to show you. So you can see the ribs here, these 3 ribs here, and there's the big mass. And then there it is on the other side. So you can see the ribs here. So this is the back surface of it, and it's just this large solid mass here. So it was very well encapsulated. They had to take some pericardium with it as well just to get margins, but it is a chondrosarcoma. So he's good age for it. It's the most common location. 2/3 arise from the anterior chest wall and often are associated with the rib cartilage. And you wonder how it got so big. I think part of it, he's apparently a really large patient. I mean, just overall tall and everything. He's got a subcu fat there, so it may not have been palpable for some time. And also, a lot of it grew deep inside the chest wall there. So yeah. I don't think I've seen one kind of grow like this, but I showed that smaller one last week, but it's just a companion case. So large chondrosarcoma. So for you, David, here's the gross picture of the chondrosarcoma. You can see the ribs, intact chest wall, and there's the tumor. It was sort of this is the other side of it. So it was sort of bilobed across both sides of the ribs. Okay, this is kind of a fun case. This one I had encountered. So this patient became mildly hypoxic after a shoulder arthroplasty. Here is his radiograph from about a year or so before. You can see his bad OA and nothing going on in his lungs. And now we have this picture. He's got a new elevated right hemidiaphragm, and he's got new basilar atelectasis. And so typically, a lot of times when they do these shoulder surgeries, they do a nerve block. And so he had an interscalene brachial plexus block. And on occasion, sometimes the phrenic nerve roots can be involved, depending if you're a little medial or something. I don't know enough about the procedure, but we've seen a couple of these before, and they're almost always self-limited. And
yeah, very interesting.
Yeah, you could always ask the question, well, maybe it was elevated beforehand, but you would hopefully have picked it up on physical exam. Or if you had a CT, that would show that the crus was not atrophied if it was an acute process. So he eventually did fine after this. And he was a big guy. I think had some obstructive sleep apnea, so it was a little tougher on him, and he required some BiPAP support, but overall turned out fine. So nice little case of transient phrenic nerve palsy from a regional nerve block.
Yes. Was there a follow-up radiograph to show that the right hemidiaphragm went back to normal position?
No, they actually wisely opted not to get one since his symptoms went away. But yeah, it would be nice to have one just for fun. And he may still get one later, but I followed up on it this morning and I hadn't seen anything. All right, so this is a nice case, and I'm going to show 2 cases where the pathology is different than what one would expect. So you see right now the frontal radiograph. Let's see if it's going to let me show both. I don't know why it's not letting me show both. I'm going to change something. Let's try something here. Stop showing screen. And let's try this. There we go. Now you can see both. So this is a pretty good classic. It's a great case for trainees. Guy comes in short of breath, and we've got a nice example of this hazy opacity on the left. You can still make out some of the hilar structures. There's the bronchus. There's this lucency around the aortic arch. You can follow the descending aorta down. And on the lateral view, you have this interface running vertically here in this opacity. Now the retrosternal clear space is filled in. It's tough to see though because he's got arm tissue overlying both sides. But this is a pretty good look for a left upper lobe collapse. This is a patient with cirrhosis and a smoking history, so most likely you'd be thinking of a lung cancer. So he had a CT scan, and it'll show the same findings. You can see there's the collapsed upper lobe, and this is why you get that lucency around the aortic arch, is you have aerated lung right there. So that's the Sickle sign, and why you get that hazy opacity is you've got a consolidated or collapsed left upper lobe, but then you have this aerated lung behind it. And then right in the bronchus here is a filling defect. So probably a lung cancer. So you underwent a bronchoscopy and a biopsy. And interestingly, it was not a lung cancer and came back as, there we go, a diffuse large B-cell lymphoma. So I've only seen a handful of lymphomas in the airways. This is, fewer than 5. I've seen a tracheal one before, but so I mean yeah, just an unusual case of lymphoma. And this is the only site of disease, as far as I know, has a small effusion. So probably better than a lung cancer, although diffuse large B-cell can be more aggressive. So, but
and on the mediastinal windows, can one perceive that there is a mass in the about the left upper lobe, or is it just hard to tell?
Right there, I think. Yeah, I don't see a discrete mass. I just see an endobronchial lesion right there.
Okay.
Yeah. All right, and then the case that goes with it is this is a 37-year-old who presented to the emergency department with some respiratory symptoms and had this mass on frontal and lateral radiographs, kind of ill-defined, maybe mediastinal, maybe in the lung. Had a CT scan at that time that shows this sort of mass-like area of consolidation with some nice air bronchograms in the middle lobe there. No pleural effusion, no lymphadenopathy. So it's just some mild reactive nodes or slightly enlarged, but nothing exciting. So you could think about community-acquired infection, and one of the things I always talk about is blastomycosis, and this would be a really good look for blasto. And so we raised that question. I think he had a fever, maybe a mild white count, but just something to think about. We suggested infection, but included specifically blasto, given the mass-like effect. So he ended up getting a workup, and the infectious disease workup was negative, and he had a bronchoscopy with a biopsy, and this came back as a extranodal marginal zone lymphoma, so a MALT lymphoma. And we've seen MALT lymphomas before, usually, and they can present as masses, solitary or multifocal, and can look like organizing pneumonia. It wasn't really on our radar at this point. It's not something it's kind of a rather large one. But so two different lymphomas in the lungs, sort of mimicking things that we otherwise would think of other things. It would not have been my first choice. So I've decided pulmonary lymphoma can look like adenocarcinoma, can look like infection. We've seen pleural lymphomas before, and then add endobronchial yet to another cause.
Jeff?
Yeah.
So lymphoma is famous for air bronchograms, even back in the plain film days. So
yes,
just nice air bronchograms. And I think that air bronchograms argue a bit against fungal infection, although you showed me a counterexample recently.
Yeah.
But I still think that there's some value in that.
Yeah, we see it, but usually in the acute blastomycosis, we sometimes, because it's just consolidation, we see air bronchograms. It's not like an invasive fungus that's digesting everything in its way.
Got it.
Yeah. But yeah, the one thing, if you look at it, though, it does have pretty discrete margins, which I frequently point out to my trainees that often infections are a little bit more shaggy around the edges, but it had a little bit of shagginess. But yeah, that's why we have biopsies. All right, I'm curious what you guys think of this case. So this is a 32-year-old male who has has sickle cell disease and came in with some chest pain, didn't have pulmonary embolism or anything, but I don't recall, and we don't see CT a ton of these patients, seeing these funny sort of beaded, dilated peripheral vessels throughout the lungs in patients with sickle cell. But it wasn't in just one area, it was sort of everywhere. And I'll make some MIPS real quickly just to kind of show you what I was talking about. Change the contrast a little bit. But if you look out in the periphery, you got these funny dilated vessels, these kind of irregular shagginess. I don't know, David, I know you've seen a fair amount of this, and I'm sure Travis probably sees some in San Francisco, but I mean, I guess it's just the sequela of long-standing sickle cell and microinfarcts and slow flow and, you know, ischemia. I don't know. Have you ever seen any?
No, I don't think I have. Sickle cell vessels.
No, we see the scarring in the bases. We see the, you know, some of the other findings, but I don't ever recall seeing abnormalities of the pulmonary vasculature.
And sometimes with, you know, take me a while, but do you think those are arteries rather than veins, right?
Well, I think most of them are arteries, but some of them look like vein. This is a vein, for example. You can see all the side branches coming into it.
Oh, I know that. Yeah, no, I don't know. Don't know what that is.
Yeah, it almost kind of looks like the telangiectasias you see with hepatopulmonary syndrome, but they don't go quite out to the surface, and they're a little bit more beaded. But yeah, I kind of chalked it up to the sickle cell. Would be kind of my thought. Okay, I'll go quickly. I'll show this case. This is just a nice case. So this is a 3-week-old or something that was born cyanotic, and you can see the heart's maybe a little big, and you don't see a really good aortic segment, but with newborns it's tough. But this is just a really, really nice example of a Tetralogy of Fallot with pulmonary atresia and large MAPCAs, major aortic pulmonary collateral arteries. So there's the VSD. You can see the thickened RV. There's the main pulmonary artery, but you can see that the RVOT is not formed at all, really, or it's hypoplastic. So there's pulmonary atresia. And then you can see if we come up the aorta, so there's the aortic arch. And then you coming down, here's the first MAPCA, this vessel coming off anteriorly, goes to the left. There's another one here on the right that's actually quite large. And then there's a third one right here, a very large one, going down to the left lower lung. So the plan to treat this patient is to take these MAPCAs and plug them, disconnect them from the aorta and plug them into the pulmonary artery, since that's what's, since these go to the lungs, and then to build an RV outflow tract and then close the VSD. So it'll return the circulation to the normal location. But this is one of the best examples of MAPCAs I've seen. I've seen a couple in adults, but these are pretty big ones here, and you see these with the pulmonary atresia. He doesn't have right aortic arch, so I don't know if he's got the 2211Q or 22q11 deletion, which is associated with the pulmonary atresia and but it usually has a right aortic arch with mirror image branching. So I don't know about any of the genetics of it, but just a nice tetralogy follow-up. All right.
Yeah, great.
All right, who wants to go next?
I have a couple.
All right.
Is a mass apparent on your screens, John?
Yeah.
Okay.
Ouch.
So we have this very well-defined, huge thing here that is pushing the trachea around and filling the right hemithorax, upper right hemithorax, all the way out to the edge. And it has strikingly low attenuation around water, and it's very homogeneous, has a thin wall, and it's some sort of a cyst. And this was resected. It had a fibrous capsule. It was adherent to everything, so it was a difficult resection. And the surgeon pointed out how hard it was and how long it took and all of that. And at the end of all that, the pathologist couldn't decide what it was because it didn't have an endothelium or epithelial layer for them to identify. So the considerations were that a thymic cyst or a pericardial cyst. my notion of pericardial cyst is that they are usually not adherent and they don't have a fibrous capsule. So I'll bet you that this is if I had to choose between those two, I would say it's probably a thymic cyst, but who knows for sure. So a large cyst, and its origin is not really very clear. Okay, so then here's I think a young woman who has this convexity to her mediastinum, and you can see it's somewhat anterior here. And this, I hope I can bring this up in order here. This also has interesting attenuation to it. So the attenuation in part of this lesion is around fat density here. So as you would expect, this is a germ cell tumor. This was a mature teratoma, and the fat is the clue to this. So the fat density here. So this isn't water density, it's actually fat density, but it's not homogeneous. There are higher attenuation soft tissue components to this as well. So mature teratoma. So
all the ones we've shown here usually are anterior mediastinum or to the right side. This one's odd, it's on the left side.
And there was some discussion earlier too. I think Jeff made the comment that these things are usually in males. Is that right? I mean, am I getting that right? That mature teratomas are more likely to be in boys than girls? I think that argument was adduced, but I'm not, I don't remember precisely. So this is a female, youngish female, and here it is in the location where it chose to be. So we'll just have to suck it up. Okay. This fellow is looking better at this point. I'm sorry, go ahead. Was there another comment? So this is the result of resection. So the lesion has been removed and now pretty normal looking mediastinum and nice clear lungs. Okay, this man has myeloma and has a lot of lumps appearing on his chest radiograph. This is from earlier this month. So some of these blobs you can say are associated with bones, but some of them seem to be floating away from bones. This one seems to be aligned with bone. This one is floating away. And this person has a striking CT scan because turns out there's myeloma all over the place. So there's myeloma in subcutaneous fat here. There's a subcutaneous here, and some big deposits in fat here, and in anterior fat over the abdomen as well. So lots of stuff deep to the skin. There was also, I don't have a contrast study to show you, but there was also a big liver lesion in this guy. And then inside the thorax, he has many of these blobs that are associated with ribs, but there's not rib destruction. So it's not as if it's burst out of the rib. It seems to be next to the rib. And there are others of these lesions that are independent of bone. For instance, back here, you can see some things that are near the spine, but not really touching the spine, this thing here, and stuff like that. And we even have lesions, here's one that's independent of rib. We even have some stuff in the lung at this point too. So this is widespread extraosseous myeloma. And the fellow was, I think he had an earlier transplant or chemotherapy, but he is now given CAR T cells, and a lot of the stuff has regressed. So in the last couple of weeks, his chest radiograph has cleared up. And on a repeat CT just a couple of days ago, most of the lesions that we're seeing here in skin, subcutaneous fat, and chest wall have regressed substantially. So things are better on his latest wave of therapy.
Gosh, that's interesting.
Yeah. So this, myeloma sometimes behaves like lymphoma in terms of just choosing to reside in soft tissues. It doesn't have to stay associated with bone all the time. Okay, this fellow has been treated for a long time for a lung adenocarcinoma, and that's why his right hemithorax is so messy looking, and he's had I think he's had pleural metastasis and things like that. So he's had a lot of treatment. But the interesting current situation is left lung base, and left lung base looks pretty good here, except maybe there are some fat vessels, fatter vessels than you would expect. So let me show you what this looks like CT-wise. And we see that in that base, there seems to be a proliferation of little dots. And these are actually small blood vessels. So we have this concentration of small blood vessels down here. And the reason is that he has this big artery going out into the lung and supplying that left lung base. And that big artery, if we follow it back, arises from the descending aorta. So here it is coming off the, I have a new mouse here, and it's a little uncooperative. So it coils around here, it loops around, comes off the anterior aspect of the aorta, and then loops into the lung. So, you know, this was looked at and people said, is this a sequestration? So I think we can answer that question. Look at these normal airways in that part of the lung that has this systemic arterial supply. There's a normal airway here, and this, if we follow these airways back, they connect to his regular bronchial system here. So this lung is not sequestered, it's not isolated from the airway. It is normally ventilated here by regular things. So this is just systemic arterial supply. It's not sequestration, which has as a component systemic arterial supply, but demands that there be isolation from the airway. So the airway, we don't have the airway isolation, we don't have sequestration, we do have just systemic arterial supply. So this case just helps to make the point that not every systemic arterial supply, and this is congenital, this is not acquired, is not sequestration. How do we know it's congenital? The size of this artery, this anomalous artery here, is not what you get with acquired vascularization, neovascularity in the setting of chronic inflammation. You're going to get a bunch of tiny little irregular vessels. You're not going to get a big factory installed pipe like this. This has to be congenital just by its caliber. So sequestration, there's such a thing as sequestration, and there's been an argument that you can get sequestration like things from inflammation. You can get acquired sequestration, but those are really, that's called pseudo-sequestration. And the vascular pattern is different with pseudo-sequestration. It's beaded, small, irregular vessels. It's neovascularity. It's not congenital arterial installation like this case. Okay, so systemic arterial supply, not sequestration. Okay, those are my cases.
All right.
Excellent.
Thanks for making the point about the sequestrations. That's a very valid point. I think you taught me that when I was a resident about the big fat artery.
Mm-hmm.
All right. Howard, I think Travis
Okay.
stepped away for a minute.
Okay, here is the first patient. The dominant finding on the right side are findings consistent with right paratracheal lymph node enlargement, certainly. There are also opacities in the right upper lobe as well, so pulmonary disease and regional nodal disease. So let me show you what that looks like here. Very extensive lymph node enlargement. And there's also pulmonary opacities. The lymph node enlargement is really extensive. It's not obviously just paratracheal, but also other mediastinal lymph node stations are also involved. And I'll show you some more images in a moment. And this isn't the first CT that she had. This is, I think, the second one. So I'll just give you a feel for what these lung opacities look like. And of course, they're contiguous in part with the mediastinal pathology. And I will show you too that, here they are, that in addition to them, and new from a previous CT that I'm not showing you, these lung opacities are new. So these lung opacities, ground glass attenuating, and also consolidated in the posterior, subpleural, right upper lobe were new from a previous exam. Now let me show you the coronal. I was initially hoping that this could be a benign process, but it turns out not to be. But that's what I was hoping because it's a relatively young person. So let me go to show you the pathology in the mediastinum that you see there. But here you get an idea for sure that if you look at this vessel going to the right upper lobe, it is severely narrowed by the pathology in the lung. And in fact, as I scroll around, if you look at how many vessels we see in the right upper lobe that are opacified of normal caliber, it's really hard to find any. There's some. But the question, of course, then is how many of these opacities contiguous with that process are abnormal vessels that are occluded? And I think the answer is undoubtedly some of them are, at least, because, and I'll just go to the lung window here, there's a lot of pathology, but I like to think that this is ischemia. So we have these peripheral opacities. To go back to the mediastinal window, there's no enhancement within them. And certainly on this, they have many features of the kind of opacities we see with, say, acute pulmonary embolism, where we have foci of pulmonary hemorrhage in the lung, we have disordered aeration. But as a new finding with the extensive vascular abnormality, I think I'm pretty confident that the peripheral ones are a sequel of pulmonary ischemia because of vessel narrowing and vascular compromise by the tumor. This is a small cell cancer, turned out to be, with a lot of disease. But the vessels, I think, are very, very abnormal. I don't have proof of that, but I think we have strong presumptive evidence for that. And here's the PET. Sorry, go ahead, Jeff.
I was going to say, I think, yeah, especially since it's small cell, that makes sense because those can grow rather quickly and cause the ischemic injury a lot faster than a non-small cell, which slowly sort of pinches off vessels.
Yeah. And of course, it turns out to be a lot of disease, bone as well as supraclavicular disease on the PET. And you can see where the FDG avid tumor is on the PET. But perhaps some of the other stuff is, who knows, vascular occlusion, thrombosis, tumor narrowing, just a combination of things on the CT. What you see there. So with that case, I'm going to show you another one with very similar findings, but even more dramatic in this unfortunate person. So this is a person that was diagnosed with a colon cancer, and either at the time of diagnosis or very soon thereafter has CT evidence of metastatic disease to nodes, not just intrathoracic nodes that you see there, but also supraclavicular nodes. These were biopsied and did show metastatic disease. So that goes back to October of last year. So she was treated for that, but unfortunately things are not going well in terms of response. So let's go forward to June. Let me just show you that. What's interesting, well, there you see it, what's interesting. Now we have calcifications within lymph nodes. We have a lot of calcification in multiple locations in the chest, but particularly in the right upper lobe. And then we'll see that calcifications are also present within metastatic lymph node disease in the abdomen as well. So this is an adenocarcinoma with mucinous features. So we can certainly see calcifications within tumor, including metastatic tumor in this instance. But now I want to show you, let me just have a look at this, that she has a lot of disease in her chest. So I'll just scroll through this just to give you a feel initially for the pattern of disease within the lungs. So I'll scroll down just to give you a feel for what these lesions look like on the lung window. In addition to the large ones, look at the smaller nodular as well as tubular branching opacities in all lobes of various sizes in the chest. And then I will go forward again more recently to show you that this has progressed a lot. So there's a lot greater burden of disease. Now we have pleural fluid. But in addition to that, we have this opacity. So that focal opacity is similar to what I just showed you. It has the reverse halo sign. To go to the lung window, we can see it's not an enhancing opacity, but it has a ground glass attenuating core, very consistent again with the focal area pulmonary hemorrhage and or infarction. Now let me show you the extent of vascular disease on the coronal. First, with respect to the big vessels in the lung, this coronal dramatically shows one how much vascular disease there is in relation to even these big vessels. They are very narrowed. There's a large tumor burden in the walls of them, perhaps inside of them, perhaps both, and it's very extensive. And in fact, if you go to the lung window, you'll see that the whole right upper lobe is less attenuating than the left. And to go back here, and if you scroll around, you'll see that you can't find any nice vessels in that right upper lobe. So there's a extreme amount of vascular occlusions involving all the vessels in the lung. We have the vascular tree and bud pattern in multiple locations, but it's particularly affected the right upper lobe, and undoubtedly with substantial ischemia in the right upper lobe has developed. So I must say this is one of the most dramatic cases of vascular tumor I've seen in a long time. It's really dramatic and really progressing.
It looks as if it just sort of bursts out of the vessels, goes down the vessels and then, surrounds them too.
Just grows out of them in the wall.
Yeah.
Just awful. More one looks. I think it's pretty likely when I see septal lines and peribronchial fluid cuffs that there's lymphangitic tumor spread as well. And just an awful situation where there's a rapid progression of disease involving all of those things, unfortunately.
Howard, it's interesting. This is a pattern more commonly seen with renal cell carcinoma with the endovascular components.
Yeah, we certainly see that. I see that more commonly, it's true. But in terms of what you sometimes call the shaggy vessels, or at least related to pulmonary veins, these are awfully shaggy, aren't they? It's just terrible.
Nice example.
Okay, so that's really unfortunate. This is a very strange case. I think that, let me just stop that. If I was looking at the CT, it's a kind of case where I'd go right behind the interesting findings, it turns out. So this was in the context of a general cardiac workup, a history of cardiac ischemia. But just look at the appearance of the left ventricle, which I think if you're scrolling just like that, you can easily go by. I think I might have gone by it. But just look at this wall right here. So this is the lateral left ventricular wall, and it's really bulgy. It's really bulgy. I don't have any thin cuts to make nice NPRs. I've just got these. And this one is even worse. It's very noisy. But I think it's dramatically shown on this one from the 10th. So this turns out to be a left lateral ventricular wall aneurysm attributed to chronic ischemia. Typically, I think we see aneurysms involving the apex, where one sees the big bulge representing the left apical left ventricular aneurysm. But here is the description of the operation, and you can see how big this aneurysmal dilatation of the lateral wall is. And basically, as you can see, they actually excised it and patched it up. As you can see here, so a large left ventricular lateral wall hypokinetic segment aneurysm. Have any of you seen one like that before in that particular location?
Not like that. I've seen one on the inferior wall, but it had more of a neck to it. So, but you can see the thinned myocardium too. It's quite thinned.
Here.
Yeah. What's the circumflex coronary look like? Because that sort of that distribution.
Okay, so we have.
There's the LAD and.
I don't really know. I can sort of see it here. I don't know if it's narrowed or what exactly.
It's just small.
It's small, to be sure.
Because it's probably a right dominant system. So it may have been, right there, there's not a lot of contrast in it. So maybe it was just a thrombus or something. Because that's a big territory.
Okay, yeah.
Wow.
Isn't that interesting?
It would be really easy to go over. I bet if you saw it on a coronal, it would be a lot more conspicuous.
Yeah. I tried to make a nice corona out of this. It just wasn't very nice because it's a thick section. And I don't have thin ones really. All right, those are my 3 cases, Jeff.
Thank you, Howard. Travis, are you back? Maybe not.
Oh. I'm here. Did you show some, Jeff, or
you? We're all done except you.
Okay. All right, we'll start with this one. This is a patient. This kind of relates to what Howard was, one of the cases that, or a couple of the cases Howard showed, and indirectly relates to it. So this is a patient who had a CT last month or 2 months ago and has a bunch of nodules, and they were coming in with infectious symptoms. And it's kind of interesting because first you wonder if they're central-lobular, but some of them touch the pleural. So I don't really know what the infection is or was, if this was viral or some sort of disseminated infection. He had this more discrete consolidation you see in the left upper lobe and a little bit of ground glass and septal thickening confined to that lobe. You don't really see much here on the non-contrast study, but certainly when you see anything confined to that area, it could be a more superimposed pneumonia, which is what it was originally called, or on the follow-up CT that was done to look at his aorta. Here you can see that the septal thickening consolidation in that left upper lobe has increased. And so whenever you see something confined to that, always look at the pulmonary veins. And sure enough, here we see that the left superior pulmonary vein is very tight. So he had a recent left atrial ablation for atrial fibrillation. And so this is either super high-grade stenosis or focal occlusion of that left superior pulmonary vein. So this was called just worsening pneumonia at this point, but of course this looks like it's a venous infarct with probably some areas of hemorrhagic infarction and septal thickening confined to that left upper lobe. And again, the nodules are there. I don't know, we didn't know what those actually turned out to be, but I saw this follow-up the other day, and now you can see that the nodules have resolved a couple months later, but we still see a little bit of improvement, but still ground glass opacity, some asymmetric septal thickening in that left upper lobe, and the same thing with that left superior pulmonary vein out. Now the left inferior one is stenosed as well. You can even see a little bit of a waste on the right side where they did presumably where they did the ablation. And now he's even starting to get has developed some big bronchial arteries, which we sometimes see in these patients as well. So, it's an example of having 2 different things going on, but whenever you see asymmetric septal thickening ground glass, what looks like edema confined to a lobe, always look at the pulmonary veins to see what it is. So Howard, you showed an infarct from cancer, right? I was peripherally listening.
Yes.
So
cancer.
And that probably accounts for why he still has a unilateral pleural effusion as well. So
yes. Yeah, very interesting.
We seem to not see these as frequently as we used to in terms of AFib ablation. I certainly don't see them when they're performed at our hospital. So this was a patient done elsewhere, so I'm not sure exactly the technique used or the experience of the person doing it, but it still happens occasionally. Now here's one. This is a patient who's 31, previously healthy, comes in with neurologic symptoms, and this portable radiograph. On portables we often see widening of the superior mediastinum just from fat and technique, but there's something going on up here. You can see it looks like there's some consolidation in the right upper lobe here, and then not sure which of these interfaces is or should be the lateral margin of the superior vena cava. So it just looks like there's too much here. He had a CT that I saw a couple months ago, and I was waiting for follow-up on this. And you can see what that corresponds to on the CT, which is both consolidation in the right upper lobe, a bunch of nodules and nodular areas of consolidation, heterogeneously enhancing, but then contiguous involvement of the vertebral body. And it looks like there's a big paravertebral abscess and some enhancing soft tissue extending into the mediastinum here. So this is just to show you he has a pathologic or compression fracture of a level with, you can see this epidural extension of presumed infection. You'd think about cancer, but certainly not in a young patient and not with the adjacent nodules and whatnot. So this is one where, we thought maybe this was going to be TB. In our neck of the woods, cocci is always on the differential, and apparently he had skin lesions, and one of the skin lesions looked classic for coccidioidomycosis, which is what they biopsied, and it did in fact turn out to be cocci. So this is cocci, and I don't know, and I'm curious what you guys think. Like, it's chicken and the egg thing, right? Like, which came first? Was it pneumonia with direct extension into the vertebral bodies here, or was it vertebral involvement with direct extension into the lung? And I guess I think it's probably infectious and then extending in. What do you think?
Yes. I think this was
pneumonia.
The primary site of lung infection adjacent to chest wall.
Yeah, and it just necessitated invaded into the mediastinum.
Well, cocci is famous for forming fistulas and for invading across.
Yeah.
So this is just utterly fine for it. It crosses the pleura and up in chest wall.
Yeah, and when he was transferred in, I think there was more suspicion of maybe him having cancer, just because this is how cancer often behaves. But yeah, I've seen this I remember seeing one dramatic case of blasto when I was in St. Louis. There was multiple vertebral body involvement, and certainly we've seen TB with this. I can't remember many cases of cocci doing this here, even though I agree with you, David. It's like most fungal organisms that can do this. So that leads me to this one.
No, pretty dramatic.
So that leads me to this one. This is sorry, go ahead.
No, go ahead.
So this one, 27-year-old, and this study was being done. The history was eval for sarcoid. This woman has a long-standing history of uveitis. So often when we see eye stuff, that you think it could be a granulomatous, process. She's been immunosuppressed for several years, and recently had onset of respiratory symptoms, dry cough, over the course of a month or so. And in this case, we see now that there are clustered nodules in a perilymphatic distribution, mostly confined to like the lateral basal segment of the left lower lobe, some of the other basal segments as well. And we have lymphadenopathy here in the left hilum that, as you can see here. Now, certainly sarcoid can give us perilymphatic nodules, but there's several things going against that. Number one, the asymmetric involvement of the left lower lobe, and number two, the necrotic appearance of some of these lymph nodes. So given our patient population here, we came down pretty
Travis,
hard.
maybe also,
Yeah.
before you go, are any of those opacities bronchiolar opacities, that is intraluminal material in bronchioles in there? I think some of them a little higher.
Let me go back to the sharper lung window here.
A little higher, more superior. Keep going.
There's some airway narrowing from the lymph nodes.
But in the periphery of the lung, keep going a little bit higher. The reason I say that is because if you think some of the opacities represent intra-airway secretions or pathology, then, well, I won't say anything more, but I would start to think of something else I think you're going to get to.
Yeah, no, I totally agree. Right. And as we've talked about with granulomatous infections, often you see, combination of central lobular nodules and perilymphatic nodules, like with TB or anything, other granulomatous infections. And so certainly there's a lot going against sarcoid, namely that it's asymmetric, it's in the lower when you have the necrotic, centrally necrotic lymphadenopathy. So this is one we thought was going to be coxy, given that we see that so frequently with this kind of look here. They bronch this patient, and this one turned out to be tuberculosis. So still right, given that it's a granulomatous infection, but wrong on the species there.
Yep. And perhaps they might blame it on infliximab because
and that's right
about that.
Yeah, so exactly. So I don't think that this is the cause of the uveitis. They've had it for years, and it was originally diagnosed as a non-granulomatous uveitis, which is as much as I know. But yeah, she's been on immunosuppression for years, and I think it's probably made her susceptible to infection. So
yeah,
I think just but we were very, came down very strongly that this is not sarcoid, given this appearance. So, all right, that's all the cases I have for this week, Jeff.
Perfect. Well, thank you, everybody. And
thank you, everyone. Those were very interesting.
Yep. All right. Well, take care.
Thanks, everyone.
Thanks.
Bye-bye.
Thanks, guys. Have a good week.
See ya.